Hi everyone, welcome back to this final part of this topic, and it's on blood pharmacology. Now we're going to start off with drugs that increase clotting, and also we'll have a look at anti-platelet factors. So the things that we're going to be talking about are being able to explain the benefits and risks of using drugs that decrease blood clotting, but also those ones that increase blood clotting. We're going to be looking at the mechanism of vitamin K, exogenous clotting factors and antifibrinolytic drugs that are used to treat bleeding disorders. Then we'll move on to look at aspirin as an antiplatelet factor. We'll go over how it causes damage to the GI tract again, and then we'll talk about antiplatelet factors and when they're likely to be used. So here's an overview of this part of the topic. We're going to start actually down here and looking at bleeding disorder treatments. So these are treatments that are used to prevent hemorrhaging or blood loss. Then we'll move on, we'll talk a little bit more about these ones here. So these are these hypercoagulation treatments to prevent thrombi and emboli from forming. We will spend more time on this because, hypercoagulation disorders are more common than bleeding disorders. And then finally, we'll finish up over here looking at the anemia treatments, whether that's treatment to treat the underlying issue which causes the anemia, or whether it's through the use of hematinic agents, which I'll talk about later. So just to recap, with hemostasis, we're talking about bleeding disorders when the clotting mechanism doesn't happen well enough, and thrombosis then is a risk of the coagulation pathway working too well. Okay, so we also have treatments for anemia, and here in italics are these treatments for dyslipidemia. So we are going to leave them alone, and we are going to talk about them more next week, and looking at the link between dyslipidemia, which is that abnormal lipid profile in the blood, and how it relates then to atherosclerosis. So in terms of hemostasis, drugs that increase blood clotting will decrease bleeding, which is good in this case, but increase the risk of thromboses and emboli. And drugs that decrease blood clotting decrease the risk of thromboses and emboli, which again is good, but increase the risk of bleeding. And both of these types of, categories of drugs will increase the risk of stroke, which is what we're going to look at now. So stroke is a term used to describe a focal brain injury, so an injury to a particular region of the brain. And there are two different types of stroke, hemorrhagic stroke and ischemic stroke. With hemorrhagic stroke, as its name suggests, it's describing bleeding into the brain, which is going to cause tissue damage. And it may be the result of an aneurysm forming on a weakened part of a blood vessel wall. And if it bursts, then obviously that's going to cause bleeding into the brain. With an ischemic stroke, as its name suggests, it's involving ischemia. And this ischemia, or, reduction in blood flow, is due to occlusion of a blood vessel to the brain, but, due to the formation of a thrombus or an embolism. Again, it's going to cause tissue hypoxia due to the ischemia, and, hypercoagulation disorders can lead to these ischemic strokes, whereas these bleeding disorders can lead to a hemorrhagic stroke. So blood clotting too well can lead to a stroke, and blood clotting not well enough can also lead to a different type of stroke. Now, keep in mind as well that drugs that are used to treat these two types of stroke can also cause stroke through the therapy itself. So if you were to give a drug that was, used to treat the hypercoagulation part, it might work too well, and it might actually cause bleeding and therefore a hemorrhagic stroke. Or if you give a drug for a bleeding disorder, it might work too well and actually cause thrombus and embolism or embolus formation, and that then might lead to an ischemic stroke. So it's really difficult to get sort of the dosing of these drugs correct, because the actual process of hemostasis is so complicated, between the clotting factors, the procoagulants, and the multiple, anticoagulants that occur naturally in the blood. So drugs are designed to target different phases of hemostasis. So they might be designed to target platelet aggregation, or the coagulation cascade, or fibrinolysis. So any steps of platelet plug formation can be targeted. So platelet activation, platelet aggregation, and then platelet plug formation. Remember as well that activated platelets produce factor V and also phospholipids, and then they feed in to activate the coagulation pathway. So the coagulation pathway can be sort of inhibited with these anti-platelet factors. Also, the coagulation pathway can be targeted too. Remember that it results in the formation of thrombin, and thrombin being an enzyme then catalyzes soluble fibrinogen into insoluble fibrin that forms the fibrin clot. So drugs can be designed to target this as well. So just a very quick question here. What is fibrinolysis? I think most people would know that this is the dissolution of the clot or the breakdown of the clot. So it's actually, the lysis of these fibrin fibers that are holding, the red blood cells and platelets and fluids inside the clot. And once they're broken down, then the clot is sort of dissolved. And it's dissolved through the conversion of insoluble plasminogen to plasma, which then dissolves it. And this is a really important step in, resolving clot formation, because you don't want clots forming and remaining everywhere in the body. So if we look at it just here, when we have coagulation, we get the formation of thrombin, which is an enzyme that converts that soluble fibrinogen to fibrin, and that forms, the clot. Remember as well that the formation of thrombin will promote more thrombin formation and therefore, leading to clot formation. So remember that clot formation is under that positive feedback mechanism. Now, while this clot is forming, we have this insoluble plasminogen that gets incorporated into the clot. It gets then converted to plasmin, and it's that plasmin then that hydrolyzes and dissolves the clot. So you can also have drugs, depending on what you need to do, that target this part of fibrinolysis as well. So we're going to start with bleeding disorder treatments. Remember, these are the ones that are preventing hemorrhaging. So what can be done to begin with is to increase the platelet number or activity. Now, this is not done that commonly, so we're not going to talk about that at all in this topic. What can also be done, though, is to increase the clotting factor concentration or activity. And this can be done through the use of vitamin K, or it can be used or can be done by giving a person the clotting factor that they're missing. And this could be done through a plasma transfusion. Now, this is done, but it can be difficult because remember, if you're giving somebody a plasma transfusion, they're going to get all the clotting factors, not just the one that they're missing. So it is quite difficult to get the dose or the amount correct of the one that they're actually missing. So if you do know what they're missing, then they can, the person can be given a specific recombinant protein of that clotting factor, right? Finally, anticoagulant concentration or activity could be decreased through the use of these antifibrinolytics. So this is what we're going to talk about in this part of the topic. To summarize this, we'll be looking at drugs that enhance platelet aggregation or enhance coagulation or inhibit fibrinolysis. So in terms then of treatment of bleeding disorders, this can be through the use of these procoagulants. And these enhance blood clotting and can be used to help treat either acquired or hereditary blood clotting defects. For example, an acquired vitamin K deficiency or genetically inherited hemophilia, where there is a missing or a defective clotting factor 8. And so what can be done for someone with an acquired vitamin K deficiency is to give them exogenous vitamin K. And say for somebody with one of these genetically inherited clotting disorders, and hemophilia being the example here, giving them, the exogenous clotting factor to, replace the one that they're missing. So just looking at vitamin K and in a bit more detail, it's a fat-soluble vitamin found in plants and produced by some bacteria in our microbiome, so in our large intestine. However, synthetic versions can be produced. Remember that it's essential to activate those clotting factors 2, 7, 9, and 10, and they're made in the liver. And it can be administered orally. It is metabolized, and it's metabolized or excreted in urine and feces because it is secreted in bile. So vitamin K actually plays, a vital role in the coagulation pathway because it's acting as a cofactor for these vitamin K dependent clotting factors 2, 7, 9, and 10, which then are, involved in the activation of blood clotting proteins too. In terms of missing clotting factors, as I mentioned, these can be replaced either through, a fresh plasma transfusion or a recombinant clotting factor preparation. And as I mentioned, this one, if you know what the clotting factor is that's missing, you can get the exact amount into the person that's required to replace the missing one. Antifibrinolytics can also be used. Remember, a fibrinolytic is something that's going to dissolve a clot. So an antifibrinolytic will decrease fibrinolysis to inhibit the breakdown of blood clots. They're used to decrease hemorrhaging, and this can include hemorrhaging due to the overuse of a fibrinolytic drug. So sometimes somebody's given a fibrinolytic drug to dissolve a clot and it works too well and it actually causes bleeding. So in this case, then they would be given on top of that an antifibrinolytic to decrease that hemorrhaging. And the way that they act is to inhibit the endogenous fibrinolytic factor plasminogen. If plasminogen is inhibited, you don't get plasminogen being converted to plasmin, and therefore you don't get the clot dissolving. So that's all I'm going to say about bleeding disorders, and we're going to now start talking about hypercoagulation disorders. Now remember that the overall aim of this hypercoagulation treatment is to prevent these thrombi from forming and therefore those emboli as well. And there are three main ways that this can be done. Firstly, by decreasing the platelet number or activity. And these are called anti-platelet factors that are used for this. We're going to be looking at aspirin. We're not going to be looking at decreasing the number, but we will look at decreasing the activity of platelets. And this can be done by decreasing platelet activation or decreasing the expression or block of the fibrinogen receptors. The second way that can be done is by decreasing the clotting factor concentration or activity. And so this can be done through the use of these anticoagulants. If it needs to be done acutely, heparin, and then long-term anticoagulation can be provided using a drug called warfarin. We will also talk about these sort of other antithrombin 3 independent drugs as well. And then the third main way is by increasing the anticoagulant concentration or activity. And this is through the use of these fibrinolytics. And so these fibrinolytics are dissolving clots. And we're going to talk about streptokinase and this tissue plasminogen activator. So to summarize this again, you could decrease platelet aggregation. We're only going to talk about decreasing platelet function, not number. Decrease coagulation, so decrease the amount or activity of clotting factors, or increase the amount or activity of anticoagulant factors. And then thirdly, enhance fibrinolysis through the use of exogenous fibrinolytic factors that dissolve clots. Now, drugs can be used that inhibit platelet adhesion and activation to inhibit platelet aggregation and platelet plug formation, and therefore sort of decrease the overall sort of number of platelets involved. Now, if you inhibit aggregation, you inhibit activation of platelets, also what's going to be inhibited is factor V and also those phospholipids. So that's going to inhibit the coagulation pathway as well. Now, if you look at this diagram over here, with antiplatelet drugs, any of these processes that lead to the platelet plug formation can be targeted. But the main one that we're going to talk about is aspirin, and aspirin inhibits thromboxane production. Okay, by inhibiting thromboxane production, it inhibits the release of ADP, and inhibiting that then will sort of inhibit the expression of these fibrinogen receptors. Now, if you've got less fibrinogen receptors available for fibrinogen to bind to, that's going to inhibit the formation of the platelet plug. Some other antiplatelet drugs don't inhibit the expression of this fibrinogen receptor, but they actually act as an antagonist. So they bind to the fibrinogen receptor and therefore prevent fibrinogen from binding to it. So the net kind of effect is the same. There's fewer sort of fibrinogen receptors available in this case to bind all the platelets together in the platelet plug. So just to summarize this, antiplatelet factors can disrupt any part of platelet attachment, activation and aggregation. The one we're mainly interested in is aspirin. Aspirin sort of works after activation is initiated by blocking the thromboxane production, but before aggregation. Also, drugs, as I mentioned previously, can be used that inhibit aggregation. So they reduce ADP-induced aggregation by stopping or preventing ADP from stimulating fibrinogen receptors. You don't need to know the names of those drugs. Or those drugs that reduce adjacent platelets aggregating by blocking fibrinogen binding to already expressed receptors. So these antagonists that are blocking the glycoprotein 2B3A receptor, which is just another word for the fibrinogen receptor. So let's have a look at this diagram here, which has a lot of detail, and we're really only going to focus on aspirin. So let's say there's a situation where there's a ruptured atherosclerotic plaque that will cause adhesion of platelets. So platelets will stick to that sort of thrombogenic surface of that plaque. That will cause activation of platelets, arachidonic acid generation, and then we have, activation of the cyclooxygenase pathway, synthesis of thromboxane A2, expression of those fibrinogen receptors, and then the linkage of those adjacent platelets by fibrinogen binding to those fibrinogen receptors. And the net result of all of that is that loose platelet plug forming. Okay. So if we use this non-selective COX inhibitor aspirin, you can see where it's acting. It acts to inhibit the synthesis of this thromboxane A2. Inhibiting the synthesis of thromboxane A2 will also inhibit the release of ADP. And together, this will then inhibit the expression of the fibrinogen receptor. Okay, and therefore that's, inhibiting the expression of the receptor is then going to mean that, there isn't going to be platelet plug aggregation, so a decrease there in that. Now, as you go through other studies or other subjects, you probably learn more about some of these other sort of drugs that can be used, but for this subject, we're only interested in aspirin. So we have looked at aspirin before in the inflammation and anti-inflammatory topic. Remember, though, that it's not great as an anti-inflammatory agent. However, it does inactivate cyclooxygenase and mainly COX-1. By inhibiting, COX-1, it's going to inhibit the formation of prostaglandins and thromboxane A2, which is what we're interested in this topic. So, inhibiting platelets from producing thromboxane A2 will also then inhibit ADP release and expression of those fibrinogen receptors. That will then inhibit platelets from connecting to each other by binding to fibrinogen, and therefore it will prevent platelet plug formation and platelets attaching to those atherosclerotic plaques. And low doses of aspirin, or a baby aspirin, every 1 to 2 days is sufficient to reduce thromboxane A2 significantly. So somebody who is at risk of clotting or who's had a heart attack will likely be taking these low doses of aspirin. But just remember that the aspirin, as an antiplatelet factor, it's not treating the damaged vessels at all. It's just inhibiting the production of those clots. Now, as we all know, aspirin can have negative effects on the gastrointestinal tract. We know that it's a non-selective COX inhibitor. It inhibits gastric COX-1 to inhibit local prostaglandin synthesis. Remember, the prostaglandin production in the stomach is really important because it normally inhibits gastric acid secretion and protects the mucosa lining the gastrointestinal tract by promoting the production of that thick alkaline mucus. Aspirin itself can directly, because it's weakly acidic, can directly cause local damage to the mucosa. And symptoms include gastric discomfort, so just mild gastric discomfort, but also diarrhea or in some cases constipation, nausea and vomiting. And more seriously, the use of aspirin can lead to ulcer formation. Remember that ulcers are sort of those open wounds that are difficult to heal. And also bleeding in the gastrointestinal tract. So if somebody is taking aspirin and they're getting ulcer production and they continue to take the aspirin that's inhibiting this platelet plug formation as well, that's going to increase that bleeding in the gastrointestinal tract. And if the ulcer sort of perforates through all of the layers of the stomach wall, then the gastric contents are going to, enter the abdominopelvic cavity, and that will also increase the risk of gastrointestinal hemorrhaging. Now, there is possibly aspirin resistance that may occur in some individuals. So over time, with the use of long-term aspirin, the body sort of adapts, and therefore it becomes sort of less sensitive to the aspirin, and therefore, the aspirin's not really inhibiting the platelet plug formation. However, it is controversial. Some studies have said that it happens. Other studies have said that it doesn't. So aspirin and other antiplatelet drugs can be used to treat conditions where blood clotting and thrombosis are at risk due to increased fibrinogen levels or blood pooling. They're mainly used to treat conditions involving arterial thrombosis, and that's because arterial thrombi, the main sort of composition of them is the platelets, right? So aspirin is given if somebody has known or suspected coronary artery disease, so atherosclerotic plaques building up on coronary arterial walls to cause ischemia. And that ischemia then is going to cause angina, which is that chest pain that people feel when they have coronary artery disease, and they feel this when they're exercising. Can also be given if somebody has an acute myocardial infarction or a heart attack. Also given post-ischemic stroke to prevent more clots from forming, and post-coronary surgeries as well. So angioplasty is where a tube is inserted into the groin, and then it's kind of guided up to those coronary arteries that are blocked, and it has a balloon at one end then that's blown up, and that blowing up of that balloon sometimes is sufficient to kind of open that vessel back up. If that doesn't work, then a coronary stent can be inserted, and this is sort of a metal tube with lots and lots of holes in it, and the tube can expand, and again that kind of opens up the vessel. If neither of those work, then sometimes a coronary artery bypass is required, where the actual arterial arteries that are blocked are bypassed. I'm going to stop here, and when I come back I'm going to be talking about the anticoagulants and the fibrinolytics.